My name is Todd Oberle. I'm originally from Texas. I went to college at Abilene Christian University, followed by medical school at University of Texas. I did my training in urology at the University of Maryland in Baltimore and practiced there for 3 years before I moved down here in 2009. My practice is mainly oncologically based, operating on prostate cancer, bladder cancer, kidney cancer. The key to treating prostate cancer is early detection, because when prostate cancer is found early enough, it is very, very treatable and very, very curable. By looking at those number of characteristics of the cancer, including how many pieces of the prostate biopsy show cancer, what the Gleason score is, what the PSA is, we can determine whether this can be watched and observed by checking the PSA, repeating the biopsy periodically, versus some of the treatment options. When we are able to find the cancer early, again, these treatment options are very, very effective, and we're able to cure the disease in many, many men. So PSA is a screening test that we use, a blood-based screening test we use to look for prostate cancer. It was really developed in the 1980s at Johns Hopkins, and when they initially did their tests, what they noticed is in a group of men who had a PSA less than 4, they tended to have much less cancer than the group of men who had PSA greater than 4. And so that got set as kind of a point that we referenced for many years, and that idea still is active today. We now know there are some more nuances to prostate cancer and PSA, and so there are a number of ways to look at PSA in a man. Age-based is very appropriate. So if a man's PSA is less than 2.5 in his 40s, or less than 3.5 in his 50s, less than 4.5 in his 60s, or less than 6.5 in his 70s, we can use that as a cutoff for whether we need to be concerned or not. Additionally, we look at the trend of PSA. Better than any one data point is what is the trend of the PSA. So if we see someone has been at a low level of 1.5, 2 for many years, but then suddenly is up to 4, that may be of concern, even though they're below the age-adjusted level. Certainly, when we see a PSA rise in that fashion, the first thing we do is repeat the PSA to see where is that data point going. If we see that it rises and comes right back down, that's much less concerning than a PSA that continues to rise. The most important thing is we need data. We make better decisions with more information. So having that PSA and watching the trend is what's critical. Prostate MRI is another piece of the puzzle. It is another tool that we have to evaluate prostate cancer using a special MRI called multiparametric MRI, and that is not definitive. It looks at the prostate and can give us a hint where more aggressive disease may be and help us focus biopsies. It certainly sees sometimes disease that's not there. Sometimes it misses disease that is there. So while it's an important piece of the puzzle, it's not definitive. So when anybody's diagnosed with prostate cancer, the first thing we talk about is, does this need to be treated at all? We now know that some prostate cancer is relatively benign, low aggressive. It shows a low aggressive behavior. And so there are many people who can be watched for many years with prostate cancer that is never going to be a problem for them. We know that many, many men die with prostate cancer, not of prostate cancer. There are several factors that we look at to try to determine whether their prostate cancer is aggressive or not. We look at their PSA level, the number of pieces of the biopsy that we take that shows cancer. We look at the Gleason score, which importantly is how the prostate cancer looks under the microscope. The more unlike normal the prostate cancer is, the more aggressive it tends to behave. We now have other tests that can help us understand the aggressiveness of the cancer, including genetic testing, MRI, and really it's important to take all of these pieces of the puzzle together to determine if the prostate cancer is aggressive enough for treatment. When we're looking at the prostate cancer under the microscope, the pathologist will give it a grade called a Gleason score or Gleason grade that is based on the cytoarchitecture. What does the cell look like under the microscope? And the less like normal the cancer is, the more aggressive it tends to be. And so that has been broken down to a Gleason score. These days, the lowest Gleason score we would say is a 3 plus 3 equals 6. That can go up to a 3 plus 4 equals 7, a 4 plus 3 equals 7, a 4 plus 4, which is 8, or 4 plus 5, which is 9. What the numbers indicate is the first number is what the majority of the disease under the microscope is seeing. The second is what the remainder. In other words, if the pathologist looks under the microscope and sees that this is mostly Gleason 4 disease, but there's a little bit of Gleason 3 disease, he would call that 4 plus 3 equals 7. The higher the number, the more it tends to be aggressive. Because that has been confusing for a lot of patients and doctors, there has been a trend to move towards calling a grade group. So Gleason 3 plus 3 is now grade group 1. Gleason 3 plus 4 is grade group 2, 4 plus 3, grade group 3. There's a grade group 4 and grade group 5. The important thing is that the higher your Gleason score or your grade group, the more aggressive the disease will tend to be. The first decision to be made when discussing prostate cancer is, should this be treated at all? There are certainly some cancers that can be watched, what we call active surveillance. If we see that there are findings with a patient's prostate cancer that indicate that they need treatment, we have several options, more options than ever. One of those options is surgical removal of the prostate. That is certainly definitive because the prostate, the organ, is removed. This is done these days best by robotic surgery. That's where we use cameras and instruments through small 1 centimeter incisions to remove the prostate and sew the bladder back to the urethra. The advantage of the robotic approach is magnification, finer movements, less blood loss. Additionally, as we've seen robotic surgery evolve, we are now able to approach the prostate in different ways. Initially, when the robotic prostatectomy began, it was used to remove the prostate, emulating the way we would do that in open surgery by approaching the prostate from the top and removing that to sew the urethra back together. Importantly, the blood vessels and nerves are actually underneath the prostate. So now robotically, for example, we can do what's called a Retzius sparing approach, where we come underneath the prostate and are able to identify the nerves and the blood vessels early, and that can lead to better outcomes with nerve protection to help with erection, bladder neck preservation, and urethral sphincter preservation to improve continence after surgery. So the prostate is a gland that sits at the base of the bladder. It's there for reproduction. It produces semen. There are 3 things that a man needs to know about having his prostate cancer removed. Number 1 is he won't make any more ejaculate. He can have an erection. He can have an orgasm because that's in the brain, but no fluid will come out after the prostate is removed. The second thing he needs to know is the prostate is part of the structure that keeps a man dry. And so when the prostate is removed, we tell men to expect some incontinence after surgery, meaning when they cough, sneeze, laugh, they can have a little squirt of urine. In our practice, over 50% of men are dry within 6 weeks. If those men are still leaking after 6 weeks, we send them to the physical therapist to do some exercises to make the sphincter muscle stronger. If someone's still leaking, let's say 6 months, 8 months after surgery, we can do a surgical procedure to make them dry, whether that's a sling, which is a little piece of mesh that goes under the urethra to help enforce that, or a cuff, which is a artificial urethral sphincter that goes around the urethra to close. In our practice, less than 5% of people need that. The erections are also a concern. The nerves that control the erections run right along the prostate. When appropriate, we take care to remove those and pull those off the prostate, leaving them in place. We don't see the individual nerves, we see the layer in which they live. And so kind of like taking the outer layer of an onion and removing the rest of the onion, we're peeling back that layer where the nerves live and removing the rest of the prostate. Should that have any evidence of the disease growing in that layer, then it has to be removed. Our first goal has got to be to cure the prostate cancer. When we are able to protect the nerves, we still expect some worsening of erection immediately after surgery, meaning men will need Viagra, Levitra, Cialis, oral medicine, or even injection medicine to help them with their erections. We see that improving with time, but if the leakage gets better in weeks to months, the erections really can take months to years. It takes a long time for those nerves to heal. But by using the nerve preservation approach, we're able to help a lot of men maintain their erection function.